Hello, I'm Doug Dormer, and this is the Abatement Information Masterclass, establishing the criterion standard for opioid settlement funding and avoiding tobacco failure. This is Lesson 2, the flight deck versus the paper map, modernizing municipal data governance to prove value and reduce risk. The stakeholders in the opioid settlement agreement can be broken down roughly this way. There are settling entities. These are the 46 plus states and territories. It's plus because some have added later, weren't in the initial settlement group of 46, that provide the highest level as what are called sovereign liens. They're the ones that are the architects of the state memorandums of understanding that guide how the money can be sent and refine the national agreement for each particular state. Then there are settling subdivisions. This includes both litigating, those who actually sued the same companies, and non-litigating, who are allowed to join into the settlements. And there are over 13,000 counties and cities in that group. These people manage fiduciary participants, the abatement partners, and they are fund managers at the local level. Then we have abatement partners, which might be hospitals, might be police, might be social determinants of health organizations, might be various nonprofits. They are the ones who may be the primary deliverer of the related services. Every organization, nonetheless, of the settling entities and the settling subdivisions is a party to the participation agreement and is bound by the national terms as well as their state MOU, if there is one for that state. And I think almost all the states have some form of MOU. There is a difference that we showed you on that graph with the timeline that we are in the midst of now, moving from a financial ledger to a clinical reality, moving from check passing to evidence-based abatement. We know first that we are operating within financial silos. Reporting is restricted initially to accounting. It satisfies the did we spend it, and then maybe did we spend it in the right areas. But it doesn't address what did it do? Did it work? What have we learned? We also, during this stage, have dealt with a fragmented paper map. We were trying to come up with a good simile for this. And the best we could come up with is being a pilot in a passenger plane. Are you working with reading the dials and a map? You have pieces. You have auditors. You might have consultants. You have some healthcare people available in a scattered kind of network. And is it your job to put that together, just as in a pilot might be trying to use his dials and gauges along with a paper map? Or do you have an integrated dashboard, a way to simplify and organize and analyze information? That's the flight deck part of this little simile that we're using. So right now we are coming from a world of a fragmented paper map. Data is trapped in disconnected systems and Excel spreadsheets across perhaps police or health services or other nonprofits. Also, there is no long-term, longitudinal view of the patient journey across that ecosystem. And there's certainly a blind spot because the rules don't strictly mandate clinical outcomes yet. Most jurisdictions are still ignoring the Section 6 remediation evaluation metrics. This is a temporary circumstance, you might say. This is a risk. The double audit risk. Financial compliance protects you from the auditor. Clinical compliance will protect you from the public and the press and the administrators themselves, because without both, you are at least half exposed. And finally, we notice the piecemeal trap, which is to say, people are saying we will go with safe distribution plans, safe interventions. We'll count the number of Narcan kits, the number of doses of naloxone. Those are process metrics. Measuring perhaps the reduction in ER recidivism is an abatement outcome. So we're beginning to see perhaps people tracking what did they do. We're finding much more difficulty in organizations figuring out what was the impact. Is there a specific reporting or audit requirement for a portfolio of clinical evidence in Exhibit E? Well, not really. Exhibit E is a floor, it's not a ceiling. And the hard requirement, if there is one, is buried in the state memorandum of understanding and the contractual participation agreement that is signed. But the expectation is that there's a 5-year grace period that we're now winding down for the administrative immaturity to resolve and to mature. If you don't have a built-in portfolio of evidence coming up soon in this next year or two, you aren't just risking an audit, you're risking the defunding of your community's shares and possibly even clawback. Because there is no prescribed form of clinical evaluation, 3 things are happening right now. The default is, of course, as we've said, to financing. It's a portfolio of the spend, not a portfolio of the clinical evidence. It's a state patchwork. States are beginning to release their own status reports. We recognize and pay tribute to North Carolina's CORE, C-O-R-E, dashboard, or Virginia's reporting windows as 2 examples. These are often, though, just high-level surveys. They still don't provide the deep clinical evaluations that we believe will be necessary. And it leaves us with a future vulnerability when a performance audit does eventually occur. And following the experience of the tobacco settlement, we strongly believe that it will. The auditors will look for substantial evidence of abatement. If the documents are silent on the form, the auditor will fall back to generally accepted accounting standards, GASB, or clinical research standards. But we can't wait, you can't wait, for them to tell you how to do it. The time will already be past. We're seeing a strong gap between those municipalities that have resources and health departments, public health services, and rural counties that have none of those things at their disposal. The lack of infrastructure is forcing rural and underserved communities into a fiduciary trap. They have the same risk, but none of the tools. The problem dumping strategy, outsourcing the solution to the police or the hospitals without a unified data layer. At the conference and in our discussions, we find a number of municipalities and counties are saying, I gave it to the hospital. It's their problem. I wash my hands of it. I gave it to the courts. I wash my hands of it. I gave it to the police. I wash my hands of it. Those organizations don't have the direct responsibility to the state or to the national administrators that the municipalities have. And so we think there's a real challenge there that will be exposed over the next 2 years or so. We also see what we call the safe bet stagnation. For example, defaulting on Narcan or naloxone distribution. It's a low-risk path, but it doesn't advance evidence-based practice or the discussion of how we can best achieve prevention, treatment, or long-term sustained recovery. And we see significant instances of analysis paralysis. Fear of misspending has led to millions of dollars in idle capital. Promising interventions are left unexplored. And finally, we have what we call the fragmentation penalty. Most counties by themselves don't have a sufficiently large population to be able to say we conducted a study that is statistically strong and demonstrates a practice. If you have 20 people in your county in a given year, that's not enough. But if you can collaborate with 10 counties, each of which has 20 people, for example, now you've got 200 people in your study. Now you're beginning to get interesting. Can we draw some conclusions about the effectiveness of this in the real world of a particular intervention, whatever it might be, with 200 people? That requires some measure of collaboration. Without that, we incur what we call the fragmentation penalty. So the takeaway from this high-level look at the opioid settlement agreement is that you can't wait around till someone tells you what you should have been doing all along. Now is the time to design your own answer to the question, what did we learn with all that money, and what does it mean for prevention, treatment, and sustained recovery? That's it on this lesson. Once again, here's our reminder to take our quiz, whether you take it now or after you watch the other lessons. We hope you'll take the time, the 5 minutes or so, to answer these 10 questions. So thanks for watching this video. Please return for Masterclass Lesson 3, the research mandate. How do we know what we learned from that $57 billion and how it affects care?